All right, guys, let's go ahead and get started. As I mentioned, Dr. Katani is running late, so she will be joining us shortly, but I want to make sure that you guys get the most out of this evening. So welcome back to Tea Time with an Epilepsy Specialist. If you are joining us for the first time, thank you so much for attending. And if you are returning, we are so happy to have you come back. I'd like to remind everyone that tonight's session is being recorded and will be reposted on our social media platforms. Just a quick reminder, when we get to the question and answer portion of tonight's session, I'd like to ask that you please keep yourselves muted. You can ask a question by choosing the raise your hand feature, and then I will call on you to ask your question. If you can't find that little button, it's no big deal. You can also enter your question into the chat, and I'll be monitoring the chat along with my co-host, Jessie. We'd like to give a huge thank you to our sponsor tonight, which is Aquestive, and we're very grateful for the sponsorship. And with that, I'd like to introduce you to Barbara Miller.
Hi, I hope you all can see me and hear me. I'm Barbara, I'm with Aquestive Therapeutics, and I really appreciate you all taking your time out of this evening to come and listen to Dr. Garcia. Aquestive is very excited to work with all of you with epilepsy. That's a really big focus for our company, and we're very excited to be a part with Epilepsy Florida. So if you'd like, I can go ahead and introduce Dr. Garcia. Got a little, you tell me.
Dr. Katani also just joined, so you can introduce both, and then I'll take it back.
Hi, Dr. Katani. Welcome. So let me tell you a little bit about both. Dr. Katani is board certified in both neurology and epilepsy by the American Board of Psychiatry and Neurology. And she is practicing at Advent Health in Tampa. She is a member of the American Academy of Neurology and a member of the American Epilepsy Society. And she is currently an active board member of Epilepsy Florida. And her focus is, she focuses much of her efforts on improving the patient experience and providing care for underserved populations. And Dr. Garcia, who will be speaking tonight. Dr. Garcia is a graduate of the University Nacional de Colombia, where he received his medical degree. Dr. Garcia completed
Richardson.
Join the meeting.
Dr. Garcia completed all of his postgraduate training at Cleveland Clinic and participated in both an internship in internal medicine and a residency in neurology at Cleveland Clinic in Florida. And he also did a fellowship in clinical neuropsychology, neurophysiology at Cleveland Clinic, Ohio. Sorry about that. And in 2015, Dr. Garcia officially joined Cleveland Clinic in Florida, which we're all very pleased and lucky to have him here. And he is board certified in neurology and clinical neurophysiology. He is also an epilepsy specialist and the head of the Epilepsy Center at Cleveland Clinic, Florida and Weston. And his special interests include epilepsy, intractable epilepsy, seizures, epilepsy surgery evaluation, and first-time seizures. And we're very excited to have him tonight.
Great. Thank you so much, Barbara. And for anyone that is interested in Aquestive's products for epilepsy, you can visit their website. It's sympazan.com, and I will be putting that into the chat with the link so you can check it out. And with that, I would like to hand it over to Dr. Katani.
Dr. Katani, you gotta unmute yourself.
Do you hear me?
Yes.
Okay, well, I'm just very happy to be here today again. I think we're almost celebrating our 1-year anniversary by next month of having tea time, and I'm excited about it. Thank you all for joining us, and thank you, Dr. Garcia, for your kind presence today, and welcome all. Let's get started.
Thank you so much. Thanks for the nice introduction. So, you know, this lecture is for patients. I really, you know, when I went over the slides, I really like the content of the slides. I think that patients are going to be extremely happy to hear the information that we have in those slides, okay? Please, if you have any questions at the end of the lecture, I hope this doesn't become a nagging lecture. I hope it becomes a rather very nice and exciting lecture. So we're going to talk about epilepsy and the challenge of managing epilepsy in patients with Lennox-Gastaut. We're going to talk about what Lennox-Gastaut is. I don't know how to get rid of this though. If somebody can tell me, maybe like this. Very good. Very good. So we're going to talk about Lennox-Gastaut syndrome. We're going to talk about how difficult it is to treat this epilepsy syndrome and the challenges that we have when we treat patients with very intractable epilepsy and Lennox-Gastaut. As a disclaimer, everything was created for informational purposes. The content is not to substitute any professional medical advice. All of you, all the people that is there, please, if you have any questions, of course, we can answer at the end, but also your neurologist or epileptologist needs to be informed, or you can ask directly at the end in a follow-up appointment if you guys have any more questions about this lecture and maybe the medication as well. This program is sponsored by Aquestive Therapeutics, and I'm sponsored by them as well. Aquestive is a specialty pharmaceutical company that develops innovative drugs, and we're going to talk about one of them today. We're going to talk about what is epilepsy, challenges in treating epilepsy, what is Lennox-Gastaut syndrome, challenges with medications in Lennox-Gastaut syndrome. Anything that you see LGS is Lennox-Gastaut syndrome, treatment of seizures associated with Lennox-Gastaut, and the new medication. So let's talk about epilepsy. So what is epilepsy? And there is a very easy definition. There is a condition where seizures happen again and again for no clear reason. The most clear definition is if you have 2 or more unprovoked seizures. That would be a nice and easy definition. In the United States, 3.5 million people have epilepsy, which is a significant number. Generally, 1 to 2% of the population of the United States have epilepsy. So in other words, you are not alone. What causes epilepsy? Most of the time, we don't find a cause, but there are multiple causes. It can affect any age. A lot of patients ask me in the clinic, why do I have epilepsy? Why at this age? The reality is there are 2 peaks, one peak in an early age and another peak after the age of 60. We have multiple causes, including genetics, any injury like trauma, any infection like meningitis, loss of oxygen of the brain to the brain at delivery, or maybe even during life. Those are some of the causes. How is it diagnosed? So the reality is more like 90% of the diagnosis comes in the office. When the patient tells us the history, when we do a physical examination, when we do a neurological examination, and then we do, I'm sure all of you guys are familiar with the EEG, electroencephalogram, and we generally order an MRI of the brain. There are seldom patients that we cannot get an MRI of the brain, so we order some other tests, including CAT scan or some other tests. So what is the EEG or electroencephalogram? The electroencephalogram that you can see here on the right side of your screen is a test that actually tries to measure electrical activity in the brain. And we place all these little cups and electrodes in the brain to measure that activity of the brain. We are specialized in reading this test, and with this test, we try to discern if those spells that the patient have are epileptic or not. So what do we see here? By convention, we call, there are different waves in the EEG. Of course, there are normal things and abnormal things. What we try to see is what we call spikes or sharp or slow waves. Sharp waves or slow waves. So I'm gonna give you some examples. This is a nice sharp wave that you see here in the EEG if you see my mouse. Um, and the difference between the spike and sharp wave, they have the same meaning epilepsy or epileptic activity arising from the region. Really for us, the difference is time frame. One lasts 70 milliseconds and the other lasts up to 200 milliseconds, but it's just basically a representation initially in paper, now in the computer of epileptic activity. They may happen in any part of the brain. Um, and sometimes, the reports that we write are extremely confusing. So please, anytime that you have a question about those reports that we write that sometimes are extremely confusing, please disclose or ask your healthcare professional, your epileptologist or neurologist to clearly understand what we try to describe in the EEG. But this is a classic example of what are sharp waves or spikes, and this is regular EEG. Always at the bottom, you see the EKG. If you always, I mean, if you had some questions about that, always at the bottom, you see the EKG. So seizures. Seizures and epilepsy are not exactly the same. So what is a seizure? A seizure is like an electrical storm. And that's why this figure of the brain. In the seizure is a synchronous, hyperexcited area of the brain brings certain manifestations to your body. In those, within those manifestations, you may include loss of awareness, changes in emotions, certain sensations, movements, like a grand mal seizure, that would be the most common one, thoughts and changes in behavior. Those changes in behavior may happen during the seizure or after the seizure. There are different types, and generally we divide it in two: focal and generalized. Probably the easiest way to understand what is focal and generalized, if you have this brain like this, the way that I explain it easily is focal. Let's say you have a small area of the brain that we call a focus, and that area is the culprit of the seizure. Generalized, let's say, is all the brain firing at once. But those seizures may be completely different. If it's generalized, you may see absence seizure, atonic, meaning loss of tone, where patient even fall on the ground. Clonic is a jerk of a muscle. Myoclonic, very similar to clonic. The difference is the duration. Tonic-clonic, tonic is that the patient becomes stiff, and clonic that the patient has jerking movements, and tonic that just is a stiffening, that it could be that is generally, if it's generalized, is all your body becomes stiff. And focal, we divide it now in uh, onset or aware onset. We used to call it previously simple partial, meaning that the patient stays aware and is conscious of what is happening with the seizure. And when the patient is his awareness or her awareness is impaired, it used to be called complex partial. In that case, you see the patient, for example, is staring off, and the relatives, the physician, or people around the patient stop responding and is unable to follow any commands. Those are like the main differences there. There are different stages. One stage that we call aura, another one that we call ictal, that is the actual seizure, and the post-ictal, post after ictus, the seizure is when the patient is recovering. The aura, actually aura is a Greek word and it means breeze. If you remember sailors in the ocean, when you have that breeze coming in, it alerts them that the storm, that is the ictus, is coming, that the seizure is coming, and then the seizure happens. The aura happens because there is abnormal electrical activity of the brain. Then the patient has the actual seizure, and then the patient recovers after the seizure. There is the epilepsy for me is not just a disease of the patient. Actually, caregivers play a significant role with the patient. Caregivers helps the patient to obtain information. They record the seizure. They describe the episodes. They take note of what happens every time that the patient has a seizure. So caregivers actually play a significant role, and they are I would say they are part of the disease because they are also involved in this incredibly difficult disease to control sometimes. So the caregiver always plays a role tracking the seizure. The idea is that the caregiver takes time, date, they describe, and they can tell the physician, and that's very important for us, what exactly happened when this seizure occurred, if the patient missed the medication, what exactly happened during the seizure. Example, did the patient stop responding? What arm, what leg started jerking, and so on. So really, this information, you're gonna share that with your physician. Challenges in treating seizures. So there are around 30% of the patients become intractable, or what we call refractory seizures, which means that you um, try at least two anti-seizure medications, and those patients are very difficult to control despite of other medications. Uh, for those patients, there are some other treatments that is not pertinent to this talk, but there are some other treatments you can ask maybe at the end of the talk, or maybe to your healthcare provider. Always, you gotta be ready with a plan. You gotta organize your information about your seizures. You need to have you need to discuss these plans with your neurologist or epileptologist. As an example, patients they ask me, should I call always 911? Should I call you? What should I do after the seizure is over? Always have a plan. What happens if the seizure lasts longer than 3 minutes? What happens if the patient has one seizure back to back? What happens if he doesn't respond after a certain time? All these, please discuss that with your healthcare provider. You gotta make a plan. The plan is not a standard for every patient, so that's why really the plan needs to be more for each patient. Eh, it's incredible to know that the main cause of seizures in a patient with epilepsy is that you forget to take the medication. And that's the reality. 71% of the patients, they have reported that they forgot or they missed to take the medication. 45% of the patients, they had a seizure after missing the medication. And the number one cause of seizure recurrence is that the patient forgot to take the medication. 32% of the patients, they told the doctors when they missed the doses. Not all of them, they say that. I think that you gotta be open with your physician, because at the end, we may adjust the treatment depending on your information. This is very important. Generally, I tell the patients to set alarms in the cell phone. Maybe the caregiver also helps to remind the patient. And that now there are different applications that you can use on your cell phone to try to remember to take the medication. Giving the medication is significantly difficult for some patients, for example, for pediatric patients, even for adults when they are impaired, when they have difficulty swallowing. I see that in a young adults in 14, 15, in teens years, patient has difficulty because they don't know how to swallow it, and even they ask you for different ways. Sometimes we crush the medications, sometimes they mix it with food. Some of the patients don't really take all the medication, even though the idea that when you mix it with the food, they have to eat all the meal, right? Some children, I don't treat children, but I tell you, some of my patients, they behave like children. So some of them, they refuse to take the medication. Sometimes they spit out the medication. In fact, I saw a patient today exactly with this problem. Uh, and multiple times we are extremely concerned if the patient is really taking the medication or not. So now let's go to Lennox-Gastaut syndrome, LGS. LGS is a rare but very severe kind of epilepsy that starts in childhood. It is not as frequent as epilepsy it is, but it's a small percentage of the population, around 35,000 to 70,000 people in the United States have Lennox-Gastaut. There are three findings. This is like a bucket diagnosis. I call it like a bucket because many patients may go into that bucket. Number one, the patient may have multiple kind of seizures, and if you remember that slides, the patient may have tonic seizures, grammar seizures, or generalized tonic or clonic seizures, absences, focal seizures. That's what it means with multiple kind of seizures that are difficult to control. They have problems, intellectual disability, developmental delay, and we see abnormalities in the EEG that we call slow spike and wave. If you remember that spike that I show you in the EEG, imagine that spike in all the EEG with that slow wave that is very, very slow. The three signs not always need to be present to call a patient Lennox-Gastaut. People with Lennox-Gastaut syndrome, they may have significant problems throughout their life, intellectual disabilities, social functioning problems. They may need to rely on parents, siblings, or caregivers. A lot of these patients, in fact, this picture is very relevant. They may need helmets because of the type of seizures that they have. They may have what we call atonic or drop attack seizures as well. So it's significantly difficult to control. Some of them, they have intellectual disabilities and psychological seizures as well, issues as well. The problem for this disease is that we try and we try and we try a lot of medications, but most of the time the seizures don't get completely controlled with the medications. And I have patients that may have tried 4 or 5, even 10 different medications, and they may be on board right now at the moment with 5 medications. They are very difficult to control. The goal really is to try to find a balance, like in every patient, where the patient takes still the medications, they don't have that many side effects, but at the same time, you can control the seizures, mostly seizures that may cause significant injuries, like drop attacks, like grand mal seizures. Other treatments, ketogenic diet, you know, ketogenic diet is a very important treatment. If you ask me personally about ketogenic diet, I don't have that many patients on ketogenic diet. It is very difficult to continue with the ketogenic diet once you started. But in pediatric epilepsy, a lot of pediatric epileptologists or neurologists, they treat patients with ketogenic diet, and actually it's very effective. Um, Other treatments, you may know already about VNS, vagus nerve stimulation. It's a device that generally implant in the chest, and it goes to stimulate the vagus nerve in the neck. The idea it sends pulses of activity through the nerve indirectly to the brain. Indirectly, I'm saying because it really stimulates the vagus nerve, and then the idea is somehow it goes to the brain through the vagus nerve. The VNS can reduce seizures between the numbers of the studies between 20 to 40% of the seizures in 50% of the patients. This is another type of treatment that we can use in patients that they have difficult to control epilepsy in Lennox-Gastaut syndrome. So challenges in the administration of these patients, as we discussed already, difficulty swallowing, maybe because the patient doesn't really want to swallow, maybe because it's cognitively impaired, maybe because the patient has disorders of the swallowing system. Uh, Another challenge, the frequent seizures, as I said, and the cognitive and behavioral changes, because some patients may not only have just the seizures, but sometimes they are aggressive, they have behavioral issues that are also difficult to control. So sometimes we crush the medications. At times, uh, all the medications are mixed, and it's a very difficult um, way to measure really if the patient took all the medication or not. So treatment for seizures associated with LGS, there are multiple medications, more than this here, but this is some of the medications. Lamotrigine, you may have heard, rufinamide, you may have heard, topiramate. This one that is very trendy, the CBD, clobazam, that is very important as well for patients with Lennox-Gastaut, clonazepam, and felbamate. But there are some others as well that are not included in the slide. Clobazam, going now directly to the clobazam, very important medication. I know that I shouldn't talk a little bit more than this. In my experience, I would tell you this medication is being used in the world for many years, as maybe some people that are actually in the talk, some of my patients know that I'm not from here, and even I was using this medication before it was approved in the United States. It was approved in 2011, but look at how it was approved in Europe in 1970s. And I'm Colombian. I tell you, in Colombia, we were using this medication even in the 90s, 80s, 90s, and early 2000s. Uh, Sympazan is basically clobazam. It's a brand medication. It's a film. Um and when I would tell you something. I really like clobazam. Clobazam is one of my preferred medications for these patients with LGS. It helps. It's a medication that has been approved for patients with Lennox-Gastaut syndrome in patients that are older than 2 years of age. Um, Important safety information. The idea that when you start taking this medication, you have to, of course, follow the recommendation from your healthcare provider. Do not stop this medication suddenly without even talking to your um, um, neurologist or epileptologist. Ben, this is a benzodiazepine, the Sympazan, which means clobazam, is a benzodiazepine. This medication may cause drowsiness, breathing problems, which means respiratory depression, coma, and even death. To be honest with you, we use it all the time, even though it's written here. We know how to use the medication, but we have to disclose this safety information. It can cause dizziness, sleepiness. The idea is that you don't mix this medication with alcohol. And as I said from the beginning, please do not stop this medication suddenly because you may have some withdrawal symptoms. The idea of this medication is a little bit different from other medications. It's a film, and it's really nice. Maybe Barbara can show you at the end. It's really a film that you can just put it in your mouth. It's really easy to put in your mouth. I show it in the office to my patients. It's a different type of formulation. It's not a pill. It's really a film. It debunks all these limitations that we have with some of the medications that we have to mix with food and so on. It's very convenient, to be honest with you. It reduces uh, drop seizures, as I said, drop attacks or atonic seizures in patients with LGS. It is very efficacious for that type of seizures in patients with Lennox-Gastaut. Remember, Lennox-Gastaut, as I said before, it has multiple type of seizures, including tonic, atonic, grammar seizures, focal seizures, partial seizures, in other words, and atonic as well. And this is a medication that reduces significantly the drop attacks. You can see the film right there. It's I have samples in my office, and sometimes it's just like a little candy for me. It tastes very well. It dissolves without water or any liquids. It's just you just put it on tongue and it's absorbed in the gastrointestinal system. It goes and reaches the maximum concentration of the medication in around 20 minutes. There are different um, uh, films. One is 5 milligrams, 10 milligrams, and 20 milligrams. As you can see them here, they are wrapped in a little piece of envelope. Um, and really, the patient is not going to be able to open that envelope. I tell you that because sometimes it's even difficult for me. um, as I said, you have 5, 10, and 20 milligrams film. You can use it with ketogenic diet. The idea is that some of these films may have a little bit of carbohydrate, but it's a very small portion. And the idea is that patients with ketogenic diets generally you allow 8 to 10 grams of carbohydrates, but this varies, okay? But this needs to be taken into account and discussed with your epileptologist or a neurologist if you are going to take this medication. Uh, as I said, some of the medications, even oral suspensions, may have a sugar or carbohydrates on it. So it's very important to make sure that that's going to go along with the ketogenic diet of the patient. This is this is a very important table about the competitor. This is actually a brand medication, Sympazan. This is Omfi, and then the idea is that you see here the amount of sugar that each one of the films, 5 milligrams, 10 milligrams, and 20 milligrams has, and Sympazan really has a very low portion of carbohydrates. So you can mix that for patients with ketogenic diet. I'm gonna skip this part. This is the presentation. Generally, you see 60 films, 5 milligrams, 10 milligrams, and 20 milligrams. This is about a 1 month supply. It depends, of course, of how much your healthcare provider prescribes. What you should know if you start taking this medication, this is a branded medication. Uh, you gotta ask for the medication as Sympazan by name. The idea is for patients, the idea is you have a zero copay. Uh, as I said, it has it may interact with alcohol, so you gotta be careful with that. You gotta discuss with your healthcare provider about other medications or even street drugs. Um, you gotta discuss with your healthcare provider about any other type of diseases like depression, mood problems, or suicidal thoughts if you are taking this medication. In general, there is an FDA black box warning for all anti-seizure medications, all of them, and that's why this is important to disclose. I have in my career, I had multiple patients that they had developed suicide ideation with all anti-seizure medication. So that's nothing that is extremely rare, but we have to disclose that with patients to make sure that if something like that happens, the patient discloses that information to us, and we have to change the medication if we need to. Most common side effect of this medication, I think in the next slide, it's better, is sleepiness, drooling. I would say this is number one and number two. Okay. Yeah, constipation sometimes, cough, pain with urination, fever, but this is very common. Sleepiness and drooling. Generally, when we titrate the medication, slowly going up. You see some other side effects here. In my practice, sometimes I've seen slurred speech, tiredness, mostly sleepiness and drooling. I would say that's the number one and two side effect. As I said, as by the name, and I think that's as we have. Thank you so much. So if you guys have any questions,
Wonderful.
please.
Thank you. Thank you, Dr. Garcia. We do have our first question from Judy. Hi, Judy. And she is asking if the Sympazan film can be used with tube-fed children. Did you hear me?
Dr. Garcia, you're on the mute.
Sorry for that. Let me even change this to video. Yes, you can use it with two-fed kids. You just have to put it in the same way, because this is going to be absorbed with the saliva. Occasionally, very rarely, you see patients that they have significant problems to swallow, but the reality at the end, most of the patients are still going to swallow their own saliva. So yeah, sure, it can be used as well.
Thank you. And Jillian, I see your hand up. You can unmute yourself and ask a question.
Okay, can you hear me?
Yes.
Yes.
Okay, so what if you have sleep apnea and also suffer from depression? Do you recommend Sympazan?
Wow,
Because
that's
I
a
work-
very good
Okay.
question. That's a very good question, because as you heard in the talk, it can affect your respiratory rate and so on. You know, generally, if you started taking the medication and so on, and you are stable with the medication, I don't think that you would have any problem with the Sympazan and the sleep apnea. The sleep apnea is a very important trigger for seizures, and it needs to be treated for patients with difficult to treat epilepsy seizures. Sometimes we've seen that when we treat the sleep apnea, seizures reduce significantly. That has been proven, and there are multiple studies that have proven all that. I don't think that there is a contraindication between the medication and sleep apnea. If that answer your question.
Yeah, that answers my question. I was actually taking Sympazan, and I noticed that I had trouble sleeping, and my depression increased as well. So that's why I asked.
So depression, remember, all anti-seizure medications, all of them, may cause mood changes. So it's important that you disclose that with your healthcare provider, and he'll determine if maybe they change the medication, or maybe they add something for depression.
Okay, thank you.
Thank
No,
you,
that's fine.
Jillian. All right. Does anyone else have a question?
I think Sean.
Oh, hi, Sean. You can unmute yourself first. Sean? Oh, there you go.
Right.
Okay.
Yeah. It's not so much of a question, just an observation, personally. And the doctor was sharing that, Dr. Garcia was sharing that, some patients seem to be, they function as children as it relates to how they take the medication and follow up on the treatment plan. And in some cases, I really believe that is true. But in some other cases, I realize that many times with the onset of the seizure, a lot of individuals, combined with their personal stress in life and the fact that, hey, I have seizures, some people believe that maybe if I get up tomorrow, please God, the seizure will be gone, and they lapse on taking the medication. And in my personal situation, I had stopped taking my medication for about 3 years. But I was so fed up and stressed out on taking medication, blood tests, going to the doctor, that kind of thing. You know, but eventually, thank God, I really got back myself taking my medication on time and that kind of thing. So is that an observation I wanted to make?
And to tell you something.
So, you know, I 100% agree. I think, and I always tell my patients that that's a conversation between the patient and the doctor. And sometimes patients are tired, extremely exhausted of taking the medication, even the caregivers. Oh, that's too much medication. I mean, I think that that's a conversation, and we try to find a balance between side effects and the efficacy of the medication. The idea, our main goal is zero seizure, but we also want you to have a quality of life, you know, and stress can be triggered either because of the disease itself, or it can be triggered as well because you have a very stressful life, right? So stress also plays a role in the seizures. And I have a lot of patients that I give you example. They quit their job, or they change their job, or they change maybe their hours, and seizures improve only just with that. I'm not saying that you have to quit your job or stop your job. I'm just saying it's stress also plays a significant role in the seizures.
Interesting that you say that, you know, many times people are wrong and said, did you take a tablet? You know, you have to take a tablet. And that is a stress in itself.
You know, I think, as I said, it's a conversation, and the idea that you have a good wrap up, maybe a good relationship with your neurologist, because as you said, sometimes we're like, did you take the medication? Yes or no, answer, you know, and, you know, I don't think that that's the way to treat a patient. I think that the best way is like we treat people as humans, you know, not like a normal person, you know, and I hate to say this, but sometimes epilepsy, the patient himself or herself has some kind of a stigma on the disease, and I think that we have to change this. This stigma needs to go away, and we need to treat people with epilepsy like we treat anybody else.
Absolutely. Thank you, Sean, for your comment. Does anyone else have a question now? I have one that was sent in that I'm going to ask Dr. Garcia or Dr. Katani while you guys are thinking. So in a child that has LGS, who also may have, you know, the behavioral issues, if you are able to obtain some better seizure control through, you know, whatever means of medication combination, if the seizures start to improve, do the behavioral issues also improve, or they're not really related?
Maybe Dr. Katani, you want to start, or you want me to start? I'm gonna start. Now that I talk. I'm sorry, I apologize. Okay, actually, you know what? 2 days ago was the International Women's Day. So congratulations to all women that are actually in the chat. Maybe Dr. Katani, please go ahead.
Well, I will say that sometimes the behavioral issues that come from can come from seizures because of the nature of the seizure, the surprise nature of the seizure, because the anxiety around when seizure is going to come. So sometimes when the seizure is controlled and you feel safe in your environment, that you probably won't have a seizure because you had few months of seizure freedom. So indirectly, it will control the behavior. But if the behavior is an underlying associated problem also, and the seizure medication that is given is not a medication that is given by a psychiatrist to treat behavior, because there's some anti-epileptic medication that are used by psychiatrists to treat behavior. So most of the time when we want to choose epilepsy medication, we try to make sure what are the comorbidities the patient have, what are the other problems they have. So we kind of choose the medication based on the type of seizure first, and also based on if they have migraines, we'll add the medication that works for migraine and seizures. If they have behavior, we don't use certain medication that exacerbate behavior issues, and we use medication that will help the behavior issue. So that's a broad answer. Now going back to Sympazan, I'm going to maybe Dr. Camilo to answer that question. And I will just say a word. Is a benzodiazepine that is long acting? And as we know, benzodiazepine are prescribed by psychiatrists. And in some other countries, like Dr. Camilo is from Colombia, I'm from Morocco. In those countries, sometimes they are prescribed not for epilepsy. They prescribe for insomnia, for behavior issues, and they have a broad range of prescription for non-epileptic things. So therefore, I do not believe that clobazam is to cause behavior issue unless there's underlying issues that didn't do well with benzodiazepine to start with. Your turn.
Okay, I 100% agree, you know, and I have a lot of patients that they may have seizures, and maybe when seizures are not controlled, you may see psychological or psychological behavior, such as paranoia, for example. And I have patients that they are paranoid, and as when we stop the seizures, this paranoia goes away. Second, I have patients that also have anxiety. They may have also depression, and sometimes going into Sympazan, I use benzodiazepines, and it helps significantly with this matter as well. But we have to also have to put these things together, because patients with depression, patients with epilepsy may have depression and anxiety, and there is a clear correlation, not only because of the disease, but also there is a genetic background that says that you may develop both. So yeah, the medication helps. The medication, benzodiazepines help to control this. And yes, if the epilepsy is not controlled, sometimes the behavioral issues are related to the very difficult to control epilepsy.
Thank you. All right, and who has a question now? Anyone? I think Jillian, you had your hands up again, right? Okay, go ahead. You have to unmute.
Okay, can you hear me?
Yes.
Okay, I should have asked this earlier. Should a patient with refractory epilepsy go to the emergency room every time they have a seizure?
Dr. Garcia, there you go.
That's an excellent question. And as I said, generally,
oh, we can't hear you.
I can't hear you.
We lost you, Dr. Garcia. We can't hear you anymore. I'm not sure if he can hear us. Dr. Garcia?
Maybe you could send him a message.
Yeah, let me tell him in the chat.
Because I think we switched to sign language, but we didn't get a notice.
I just messaged him in the chat. Oh no.
Looks like it's a good answer.
Yes.
I texted him as well.
Okay.
So Jillian, so we get back,
can
Dr.
you hear me?
Okay. Now we can.
Yes.
Oh, I'm not sure exactly what happened. I don't know. Where did you lose me? You don't
Didn't
know?
get
All of
any
it.
of it.
Oh gosh. Okay. So it depends. Can you hear me now? Okay.
Yes.
So it depends on the type of seizures and the type of epilepsy. I'm gonna give you two scenarios: the typical scenario, the atypical scenario. I have patients that every time that they have a seizure, the seizure lasts 15 minutes, 20 minutes. The seizure itself. I'm not talking about the post-signal after the seizure. The seizure itself. In that case, I always tell them call 911. Or sometimes they just go into status epilepticus that is an ongoing seizure. I always tell them call 911. And even I provide medication to try to stop the seizure right at the moment, right there at home or wherever they are. The typical scenario is that you have a short seizure that generally lasts less than 2 minutes. If you recover after the seizure, if you didn't have any injuries, if you didn't hit your head, I talked to the healthcare, to the caregiver, maybe to the husband, maybe to the friend, or if you are alone, if you recover fine after the seizure, if you didn't hit your head, if you don't have any injuries, you don't need to go to the ER. I generally ask the patient, once you have a seizure, call my office and then I'll adjust the medication if I have to. And I also ask the patient, please try to identify what triggered the seizure. Example, you forgot to take the medication. That's the #1 cause. And maybe you had diarrhea, maybe you had a common cold, maybe you had fever, maybe you didn't sleep well, maybe you're under stress. All this is important. All these factors are important. Okay?
Okay, thank you.
That's fine.
Thank you, Jillian. Yes, hi, Wanda. I can see you. You can unmute yourself.
Hi, do you hear me now?
Yes.
Yes. Okay. I sometimes get the back-to-back seizures, and they last like anywhere between 3 to 5 minutes. But I also, when I take the medications, I get dizzy. And I see if sometimes I see everything double. What can be done for that?
Okay, very good question. I'm going to divide it in two. The side effect of the medication, that's the second part, and the first part that you may have back-to-back seizures. So you got to discuss with your neurologist or epileptologist. There are different medications that you can use right after the first seizure to try to prevent a second seizure. You can put in some medications under the tongue, some medications, maybe you just have to take a medication quickly and swallow the medication. There are different medications that you can use for that. Number two is the second part is side effects of the medications. Most of the medications that we use are called sodium channel blockers. These sodium channel blockers, they may affect your ear and they may cause, or even the brain, they may cause dizziness. And generally this happens half an hour, 1 hour after you take the medication. And generally it lasts 2 hours or even 3 hours after you take the medication when the medication goes, when the medication peak goes away. So when you take the medication goes to the peak and then it starts going down. There are different ways to do this. Easy way, you can split the medication. If you are taking too many medications at the same time, you can split maybe, but you gotta discuss this again with your neurologist or epileptologist, maybe morning and noon and the full dose at night if you are taking twice a day. Sometimes I split the doses if it's too much. Maybe some medications at 7 in the morning, some medications at 9 in the morning to try to split the side effects and prevent that. Or sometimes something simple, you can try to change the medication from regular release to extended release, because when you take regular release, the medication has a peak and then it starts going down like that. When you have a medication that is extended release, the idea is it stays there in your blood like this, so you don't have that peak side effect that is the dizziness. And of course, you have to see which medications you're taking, because depending on the medication you're taking, if you're taking too much of the same mechanism of medication, you may develop the same side effect. Yes, go ahead.
Yes, I take the Capra extra release about 3,000 per day. I also take the Lamictal, that's 500 extra release as well per day. And I also take the Vimpat, 400 per day.
So when you have two medications that are sodium channel blockers, generally you have Vimpat and Lamictal. Those two medications, the side effect from those medications is dizziness. If you're taking a significantly high dose of those two medications, you may have that. So what I do generally is either I split the dose. You take one at 7 in the morning and the one at 9, or maybe I change. I don't know if you're taking the lamotrigine extended release or not. Maybe change the lamotrigine to extended release to see if that alone stops the side effects. But then all this you have to discuss with your neurologist or epileptologist. But again, it's because these two medications, they cause generally the same side effect, and probably you're on a high dose.
Yes.
If I get to say something, I totally agree with all what you said, Dr. Garcia. I tend to prescribe these extended release instead of 1 dose, 2 dose, to have the steady effect like Dr. Garcia mentioned earlier, because you do not want to have the dip, especially if you have refractory seizures. Your brain is very strict and it wants a delivery that is consistent and at the same time, and no change in the level of the balance between inhibition and excitation. So you may want to discuss that as well. And it probably, if you split the dose into twice a day, you will have the nice effect of a continuous same level, and you decrease the side effect because you take in a massive dose of all of them at once. So you will experience some of these side effects you described. And remember, all these seizure medication are to cause more inhibition in the brain. So they're gonna cause you drowsiness. So that's the first side effect of all of them. So if you keep adding drowsy to drowsy to drowsy, you're gonna be super drowsy. So we have to be smart about the choice of how to split the dosage, or if maybe you could get a lower dose in the morning, a higher dose in the evening, depend on what time you have your seizures. If they occur more at night, then maybe you could focus a lot more Lamictal at night than during the day. But Lamictal, again, is better to have it during the day because it may not let you sleep. So there is a lot of factors that could be taken in consideration, but one of them that I really think, based on your case that you take in high dosage of 3 anti-epileptic medication at once, is to separate the dosage to twice a day to have that effect, or maybe consider a change. Maybe sometimes there's a honeymoon period and that medication doesn't do the job for you, or consider other alternatives like semi-invasive procedures, or a little bit more invasive, or invasive, depend on what type of seizures you really have, to minimize the side effect of medication you ingest in every day.
Thank you.
You're welcome.
Thank you. And we are coming to an end, guys. So we have time for just probably one more question. Sandra had a question in the chat. Sandra, why don't you speak up so we can hear you? Let's see you.
Oh, hi.
Hi.
I'm taking Epidiolex now just for a couple of months, and I was wondering if you could just generally speak about that and what you think about it. I'm not sure if it's helping or not. And then the second question, which I'm sure everybody has all the time, is memory. And is there anything new about improving memory? Mine seems to be continually getting worse in terms of remembering nouns or names of movies or names of, you know, just things. And it's embarrassing, but.
Sandra?
Yeah.
You can hear me, right? So let me start first with the last portion, memory first. So memory is a significant complaint from all the patients with epilepsy, okay? This is one of the first complaints from patients with epilepsy. That's number one. Two, generally it happens in patients who have left hemispheric epilepsy, okay? Or we generally call the dominant side of the brain, generally is the left side, generally. Not everybody has the dominant, and the dominant, what I mean is that the memory, what we call verbal memory, is on the left side of the brain, or mainly in the temporal lobe. So a lot of people, the most common type of epilepsy is temporal lobe epilepsy, and people with left-sided or dominant temporal lobe epilepsy, they generally complain of memory problems. And there are studies that have proven that patients, after 10 years of having seizures that are difficult to control, they have a significant decline in memory. And this happens because the area of the brain involved in memory, that is in charge of memory, that the name is hippocampus, doesn't matter what the name, but the area of the in charge of memory gets damaged after time because of seizure after seizure after seizure. The second possibility in memory is medications. Our medications can cause memory problems as well. So again, we go into the same battle. We try to find a balance of no seizures and less side effects, but our medications clearly can cause memory problems, even naming problems. So you describe that you don't know how to call something. Sometimes some of the medications may cause these problems. Now, Epidiolex is a medication that was approved by FDA for three main conditions. It is used for patients with Lennox-Gastaut for atonic seizures. It is approved for patients with tuberous sclerosis and is approved for patients with Dravet syndrome. Off-label, and I just can talk about off-label. Some neurologists, epileptologists may use it also for a focal epilepsy or even for generalized epilepsy. It's a medication that it works, okay, but it's not the best medication. That is not like improvement over other medications. And in fact, in some countries, it's been approved in combination with clobazam, sympazan. And in general, in my practice, I've seen a significant improvement when I have that combination of medication, Epidiolex and clobazam. Some patients see improvement, but some are not. So it's not that the medication don't work. Sometimes it's just the epilepsy is extremely difficult to control. Also, it's important to know how much are you taking when you take this medication, because sometimes we use very low doses. You really need to maximize the dose of this medication as well.
Yeah, I just started on it. So, but I take it in with Vimpact and clonazepine when I want to take the clonazepine. But does it affect memory or not necessarily? What would you say the side effects of it are?
I would say probably not. This medication has some more, I mean, like all medication, this goes to your brain, okay? So this can cause drowsiness. That is number one side effect for this medication as well. It can cause some more liver issues. And in combination with other medications, it may cause other side effects, maybe memory. Sure, again, it goes to your brain. But from what I hear, from what you're saying, is your memory has not really changed just because of this medication. It seems that your memory has gradually gotten worse over time because of the epilepsy. So it's nothing like, that's what I hear. Unless you tell me, Dr. Garcia, this medication just damaged my memory and I feel worse with the medication. That's a different complaint.
Can you get your memory back? Is it possible to do things to improve your memory, or once it's gone, it's gone?
Yes and no. Yes, it means occasionally when we, I'm going to talk a little bit about surgery. Let's say when we do epilepsy surgery, even in patients with bad memory, patients become sometimes even more functional because you stop the seizures. So stopping the seizures is key. Patients become more functional, even though the memory is still bad. The brain works better because seizures are controlled. So I guess the answer would be your memory doesn't really get better, or sometimes may get better if the seizures are controlled with medication or with some other ways to control it, like surgery, for example.
Okay, thank you.
That's fine. Thank you, Sandra.
Okay, thank you, Sandra. Well, I want to thank all of you for joining us tonight. On behalf of Epilepsy Florida, we're so grateful. And to Barbara Miller and Aquestive, thank you for the sponsorship. Dr. Garcia, Dr. Catani, as always, we appreciate you and your time with us. And I'm sure Dr. Catani has some closing words for you.
Well, I want to say again, thank you for everyone for being here again today for our tea time. Although I didn't see anyone with a teacup, but I'm happy that you were all here and we get to share this. Thank you, Ferline. And I'm really glad, I'm happy. It makes my day. I look forward to every month till we all get together and ask questions, learn from our amazing speakers, and share experiences and learn from each other. Thank you, Dr. Garcia, for your great talk and for your presence and your time. Thank you, Barbara, and good to see you again. And thank you, all of you, for being here. And special thank you to my friend who I worked with for 10 years, almost, from New York, Miss Ferline. Thank you so much, all of you, and I'll see you next month.
Thank you. Good night, everyone.
Thank you.
Thank you so
Bye-bye.
much.
Bye.
Good night.
Good night.
Good night.
Bye.
Stay safe.
Bye.
Ciao, ciao.
Bye, everyone.
Ciao, ciao.